will come to your OPD, we always take a vision. And if vision is not 6/6, below that, then we have to see, okay, either he has a cataract or retina problem, anything else. So visual acuity is very important, and simultaneously you can see the condition of the patient also, watering or red eye. Visual acuity, if you don't have perimetry in that condition, if you do the confrontation test, it is a basic part of the knowing about the field. Depth perception, in mild or moderate type of glaucoma, you are not able to get any problem. But once that advanced stage is there, then definitely the gait of the patient is changed because they are not able to see the surface clearly, either smooth or somewhere uneven. So this is a key point for the advanced stage of the glaucoma. Do tonometry, pachymetry, slit lamp examination, or gonioscopy, or perimetry, or optical coherence tomography. So how we can manage this? Either by laser or medicine or surgery. So how many of us are doing applanation, tension, or gonio or OCT? If you people don't interact, then I will move the slide. 80, gonio, OCT, all applanation means not like other cyodes or like. So for the to make a diagnosis on the basis of pressure, applanation is still the gold standard, and we have to believe or trust on only in the applanation tonometer. Other things, gonio is just to classify either angle closure or open angle glaucoma, and incidentally you can get a different type of findings like foreign body, like cyst, like blood, like anything. It depends on the condition. So laser, different type of laser you can do. First is laser trabeculoplasty, laser suturolysis after trabeculotomy surgery. You can do that. Laser iridotomy, laser peripheral hydroplasty, and cyclophotocoagulation. So every dose, every day, it can save your sight. This is the one slogan. So which drug is still first line of treatment? Like Imolate, carbonic anhydrase inhibitor, prostaglandin, cholinergic drug, or rheokinase inhibitor. Which drug you people use, sir? You people are prescribing glaucoma medicine. Which medicine you are still first line of treatment? I am trying to make a little bit interesting. That's why I am asking. Which one, Dr. Aaron? Beta blocker. Dr. Safi, sir. Good. So, sir. Okay. So after finishing this whole talk, we will come on this point. So medicine, everybody here can prescribe and they can treat the patient. But like beta blocker, stimulate, alpha beta like alpha gal, albrine, या britican, carbonic anhydrase inhibitor like dozonamide, brizonamide, prostaglandin, rheokinase inhibitor is new medicine, netasudin or ipasudin, and then cholinergic drug. Many of us we just prescribe, but we never go for their side effects. That is a big problem because pressure is okay coming down, patient is almost pressure is okay, but we are not able to see their side effect of the particular drug. That you people have to see. Like if you are prescribing alpha adrenergic drug, see there sometimes they have a blurring of vision and allergic like papillae. Big papillae you can see in the just over the conjunctiva or contact dermatitis is a big problem of alpha adrenergic. Beta blocker, definitely you have a problem of breathing or irregular heartbeat. Sometimes there is a sexual drive changes, and in diabetes patient, their sugar level come down. So it's very difficult to know either is due to the drug or due to the medicine, systemic medicine. So they have to close the lacrimal duct after instilling the drop. And tiredness. Carbonic anhydrase inhibitors, definitely they have skin rashes if the patient have a sulfur drug allergy or taste changes little bit. Biotics, they are trouble to focusing on distance object like pilocarpine, the difficult seeing in the dark or at night, and proate. These are the side effects of the myotics. Prostaglandinola, there is permanent changes in the eye color and increase the length of the eyelashes and darkening of the eyelids. So this is the one practical point. Suppose we are prescribing one medicine. Have you ever seen what amount of the quantity is there? You please see that. Suppose one drop of vial is containing 2.5 ml. So 1 ml is equal to 20 drops, and 2.5 ml is equal to nearly 50 drops. Suppose you are prescribing any patient BID dose. So patient will use 4 drops in a day for both guys. So it will finish within 12 days. So we can count their expenditure also. We can count their follow-up also. You should come in this data. So these things we have to note. Percent of IOP reduction is also very important. Suppose you are prescribing temolizumab. So this will decrease hardly 25% maximum. Other medicine like brimonidine or prostaglandin, they have a little bit good thing. They are decreasing nearly 30 to 35%. Pilocarpine is a one drug that will decrease only 20%. But it is a magic drug. You can prescribe. If so, this is my topic. If you are have interest, so I can go ahead for the another few slides. Would we? Okay. So sometimes you are not able to make a diagnosis of glaucoma, and this condition, just see if there is a single IOP reading, it's never be reliable. So you call the patient for another intraocular pressure checkup and do with the gold standard like applanation tonometer. And if it is confusing, go for the diurnal IOP, and pachymetry is still important. Sometimes you can see this suspicious disc. You can see this disc is either glaucomatous or normal. You have to see the ISM today, definitely. So this disc is glaucomatous or normal. So definitely it is a glaucomatous. One see, because we have already catch the point. This ISM rule. See the arrow. You can hear this one inferior part is thinned out. Yeah, you can see here. This is called notch. And if you do the perimetry, similarly that condition have a scotoma in the superior part. Inferior notch, superior scotoma. So this actually coinciding the finding. Other things you do gonio, you will get another finding like some peripheral anterior synechia. So whenever you examine the patient, the disc, always remember, always try to follow this ISNT rule. You can see here inferior part is little bit more thicker than superior, then nasal, then temporal. And see in the glaucomatous pass almost these, all the rim is equal. Inferior, superior, almost this is a like bucket sign. So suspicious disc, you have to see the disc size, then this another part of the disc size, you can see this also. You can this is the same. I am repeating this slide. This is the inferior notch. So you have to see the general neurated ring. So this is the inferior notch. In this big size of optic disc, you will see here is a splinter hemorrhage. This is another pathognomic sign of the glaucoma. Here the bionetic sign. Another one, here you can see the vessels is just hanging there in the disc. So it is also a one part of the biometric sign. You can say, yeah. Then you can see here splinter hemorrhage. So the glaucomatous changes you can detect by the level of optic nerve head or just seeing the retinal or fiber layer. the one important American testing of pathology algorithm, if you are suspecting primary open angle glaucoma, so in that condition, you have to see that this. If this is suspicious, so just note either it is normal intraocular pressure or elevated pressure like 22 to 26, or intraocular pressure is 28. On the basis of that, you think first if there is a normal intraocular pressure, then you may think about the normal tension glaucoma suspect. If pressure is on the higher side, so you just treat. If pressure is 28, just start it. Don't go for another thing. All the patient for perimetry or OCT, whatever you want to do. But if pressure is higher side, just start treatment. If it is 22 to 26, go for the visual field. If it is normal, there is no risk. Just tell the patient to come every 4 or 6 months. If visual field is there, then just treat it as like a glaucoma patient. Same thing for the normal tension glaucoma suspect. If pressure is less than 22, do diurnal variation. Visual field is normal, our imaging is normal, then just leave it. Or abnormal, then you have to start follow up and do this photograph or take intraocular pressure. See the other things like this. You can see the optic disc speed, mimic the glaucoma, morning glory syndrome, or any choroidal abnormality. Same thing in a primary angle closure suspect. If there is an angle is uploadable, sign of intermittent closure you can see here. This one sign you can see here. Do nice PI, then angle is open, treat like a primary open angle case, and then start treatment. If you are treating the glaucoma patient, then you have to save the intraocular pressure. If there is a early glaucoma, this visual field change is less than 6 decibel. In that condition, your target pressure is nearly 80. And moderate, you can keep it in 15 or above 15, but 15 is okay. Advanced glaucoma is 12 millimeter mercury, and terminal glaucoma 10 millimeter mercury. How to set the target IOP? If glaucoma damage is early, set a higher intraocular pressure. That advanced, then you have to keep the lower target intraocular pressure. Same these phenomena you have to apply to all the patients. This you can see the 4 A, B, C D, the graph. A is actually the line of representing the aging effect, means no need to treatment. This definitely within the with the age, the vision is definitely poorer and poorer. But suppose you can the glaucomatous damage is started in the late age, like in your B slide you can see, and this is also not dangerous because the progression is very slow. But you can see here is a severe visual function. But in the C category, if young patient will have diagnosed the glaucoma in this part and your damage is increasing like anything and their severe visual impairment is there, treat aggressively, the target pressure should be very low. Last, whenever you feel for the first choice or second choice treatment, first you see the mechanism of action of the particular drug, the efficacy. There they are that particular drug is either preserved or unpreserved. What is the cost going to be there for the particular treatment? Is that particular drug is compromising the quality of life of the patient? What are the systemic side effects? And these things you have to keep in mind before prescribing any medicine. When to seek the medicine, if that particular drug is not working properly, as I have already in my previous slide told you that Qumulate malate have a reduction about 25%. If that drug is not going to decrease the pressure about 25%, you just change it or you can add it. So, in primary apical glaucoma, or normal tension glaucoma, or non-inflammatory glaucoma, definitely you can go for the trabeculectomy. If there is inflammatory glaucoma, secondary glaucoma, or failed trabeculectomy, go for the tube stent. In the painful blind eye, go for the cyclodestructive procedure. So, this actually I am trying to cover the key point of my knowledge for you to learn or to adapt something. Thank you.